My name is Katie Sharrett, and this is my presentation on geriatric syndromes in the elderly. Geriatric patients are at risk of geriatric syndromes because of their age, cognitive impairment, functional and impaired mobility. Of the many geriatric syndromes, urinary incontinence will be discussed. Urinary incontinence is an unintentional loss of urine, and it can be acute, such as infectious, or chronic, such as functional. Some statistics on urinary incontinence. Urinary incontinence is more common in women at an older age. Unfortunately, urinary incontinence is usually a sign of something pathophysiological, functional, or other underlying risk factors. The complications that are likely to result and are detrimental to the patient are falls, fractures, and hospitalization. Significance to the nursing profession. It is not a normal aging process and can be treatable with dietary changes, behavioral alterations, education of medication side effects, signs and symptoms of infection, and proper hygiene. RW's past and current medical history is benign prostatic hypertrophy, cognitive impairment, overflow urinary incontinence, primary hypertension, gout, peripheral neuropathy, hyperlipidemia, and CVA in 2007. Surgical history is just a right ACL repair in 2014, and previous hospitalizations was from his CVA in 2007. RW has no known drug allergies. His current medications are valsartan, which he takes 160 milligrams of twice a day. He takes a vitamin B complex, 1 tablet daily, simvastatin, a 10 milligram tablet of that daily, allopurinol, 100 milligram tablet daily, verapamil, 120 milligram tablet twice a day, timsolacin or Flomax, 0.4 milligram tablet daily, finasteride 5 milligram tablet daily, and he was prescribed meclizine 25 milligrams as needed. RW is up to date with all of his childhood immunizations. He received his flu vaccine last year in October, pneumonia vaccine in 2011, shingles vaccine in 2015, and Tdap in 2011, which means he's up to date with all of his necessary immunizations. His health maintenance and disease prevention, his last annual visit to the VA was in July. He had an eye exam in November of 2018, colonoscopy in 2014, not requiring one for 10 years. His last EKG was in July 2018 at his annual VA visit. Patient is compliant with every 6 month to 1 year appointment with routine lab work at his primary care provider, and his last dental exam was in August 2018. Typical patient presentation when experiencing urinary incontinence is dependent on the type of urinary incontinence. Transient urinary incontinence is caused by an acute issue due to medications, or chronic urinary incontinence characterized as stress urinary incontinence, overflow urinary incontinence, urge urinary incontinence, mixed urinary incontinence, which is a combination of stress and urge, or functional urinary incontinence. Stress urinary incontinence presents as loss of urine with physical activity or intra-abdominal pressure. Urge urinary incontinence presents as losing urine on the way to the bathroom, for instance. They get a sudden urge from uncontrolled bladder spasms, from an overactive bladder muscle, or a neurological dysfunction of the bladder. Mixed is stress and urge urinary incontinence combined, causing involuntary leakage with a sudden urge to urinate. Overflow urinary incontinence is overdistension of the bladder muscle or retention of urine from dysfunctional bladder contraction or obstruction. They generally complain of dribbling, unable to empty bladder, hesitancy, fullness, or pressure of the lower abdomen. Lastly, functional urinary incontinence is caused by cognitive or physical impairments. A thorough review of systems was done, indicating mild short term memory dysfunction per the patient's wife and denies any recent brain or spinal cord injuries, history of Parkinson's, or multiple sclerosis. He does have a history of stroke, but denies any current symptoms of this. Patient has no signs of depression, which was proven by the geriatric depression screening performed in office. He does have poor vision but uses corrective lenses. He has no complaints of recent dizziness or imbalance issues or requiring his meclizine. No signs of hypotension due to dehydration or sepsis, causing syncope or dizziness on standing, palpitations, or difficulty breathing. He has no cardiac history besides his high blood pressure and hyperlipidemia, which is well managed on his current medication regimen. He denies any history of diabetes as well as symptoms of polyuria, polyphagia, or polydipsia. He denies any urine loss with sneezing, coughing, or laughing, and no urgency with urination. However, he does complain of hesitancy and dribbling when he urinates, but he is able to empty his bladder once the stream is started. He has regular bowel movements twice a day with no complaints of impaction. He denies any fever, chills, or other signs of infection. Patient is able to move appropriately to make it to the bathroom on time with no environmental barriers. He has good lighting and bars in his bathroom and no stairs to climb. Patient does not drink more than 32 ounces of water a day, which may not be enough but is not excessive, especially prior to going to sleep at night. And he does not drink alcohol, but he does drink 16 ounces of coffee a day, which is known to contribute to urinary incontinence. Patient does not take any anticholinergic, diuretics, opiates, hypnotics, ACE inhibitors, or antispasmodics, which are a few of the medications that can contribute to urinary incontinence. RW's vital signs are all normal, with his blood pressure well controlled on the medications he takes, and he states that he frequently checks his blood pressures daily, and they range anywhere from 120 to 128 over 80 to 90. Physical exam findings. Patient is alert and oriented times 3. He answers the questions appropriately. He appears in no distress. His mental status and depression was screened and performed with the appropriate tools and will be discussed. His respirations and breathing are regular with no presence of dyspnea on exertion, and this was indicated from walking into the office. S1 and S2 were audible with no murmurs or adventitious heart sounds. His abdomen is soft with no pulsations, masses, or hernias visualized. No inguinal lymphadenopathy palpated. There is no tenderness or distension noted with palpation, and no presence of urethral discharge. The screening tools done on RW was first the mini mental status exam, which he scored a 23, showing mild cognitive impairment. This score was not changed from his last assessment a year ago. He did get points taken off from wrongly repeating the 3 words, points off for drawing the picture incorrectly, and he got 3 numbers wrong from counting back from 100 by sevens. The Geriatric Depression Scale, or PHQ-9, he scored a 4, which was normal, indicating no depression. The Get Up and Go test he did was less than 10 seconds. so that showed good function. And lastly, the CATS ADL screening tool, he scored a 4, which indicated somewhat dependence. He needed help with sitting up, requiring an aid or assistance with sometimes sitting up out of the chair. Of course, he has incontinence, which we know, and he also required occasional help with dressing himself. For more objective data, to determine acute versus chronic urinary incontinence, you first want to determine the time frame that it is occurring. Is it less than 6 weeks, or has it been going on for more than 6 weeks? In this patient in particular, RW has had overflow urinary incontinence on his medical history for greater than 6 weeks. Therefore, he has chronic urinary incontinence. You then look at the pneumonic diapers. RW has no current delirium, infection, new changes in medications such as taking psychotropics or changes psychologically. And this was determined by his recent mini mental status exam. He also has no signs of endocrine problems such as diabetes, but during this visit, a TSH and hemoglobin A1C was drawn. He does have restricted mobility, but that has not been going on within the last 6 weeks or less. That is chronic, and he has no stool impaction based on his review of systems. RW has chronic overflow urinary incontinence as indicated on his history, as I said. There are some medications on RW's list that fall under the common medication list that cause urinary incontinence. The only medication that may possibly cause the relaxation of the bladder leading to overflow urinary incontinence is a calcium channel blocker, verapamil, that he's taking. He, however, has been on verapamil for 5+ years and continues to take Flomax and finasteride for his prostate enlargement, likely causing to his overflow urinary incontinence. Because we already know RW has overflow urinary incontinence, these questions aren't necessary to ask, but a 3-question incontinence questionnaire is used to determine which type. These questions include: number 1, in the past 3 months, have you leaked urine? Number 2, during the last 3 months, did you leak urine while performing physical activity, such as coughing or sneezing, when you had the urge to urinate, or without either physical activity or the urge? And number 3, during the past 3 months, did you leak urine most often? When did you leak urine most often? Another diagnostic procedure done to determine type of incontinence is called the cough stress test, and this indicates stress incontinence. And you ask the patient while sitting and standing to cough, and if they've had leaking during coughing or delayed 5 to 15 seconds after the cough, then that is positive for stress incontinence. Other lab tests to be done are a serum creatinine, and this can be elevated with overflow incontinence due to obstruction. A urine analysis to rule out infection and also look for hematuria and proteinuria. A CBC, a comp panel, TSH, and hemoglobin A1C was added to this patient's lab tests for this visit to look for infection, look at the fasting glucose level and hemoglobin A1C, as well as renal function and thyroid function. And this was not performed for RW during this visit, but another Diagnostic procedure is post volume residual, where you get the patient to urinate and then measure via ultrasound with like a bladder scanner to determine what was remaining in the bladder. Less than 50 cc's is negative for overflow urinary incontinence, and greater than 200 cc's is positive for overflow urinary incontinence. The plan for RW pertains to his medical history of overflow urinary incontinence. Non-pharmacological treatment for overflow urinary incontinence would be number one, bladder training, limiting fluids before bedtime, management of his comorbidities, sterile catheterization, which can be educated to the patient or caregiver. Pharmacological treatment includes 5-alpha reductase inhibitor, such as finasteride, selective alpha adrenergic antagonists, such as Flomax, and non-selective alpha-1 blockers, such as terazosin. Taking a medication such as a non-selective alpha-1 blocker, the patient is at risk of orthostatic hypotension, falls, and injuries due to the decrease in their blood pressure. Lastly, you would want to consider referral to urology or possible surgical intervention if nothing else has worked. Barriers to treatment, as I stated, the pharmacological complications, more specific to the non-selective alpha-1 blockers, and functional limitations is always a barrier to treatment. In patients experiencing other forms of urinary incontinence, such as stress incontinence, you can educate the patient on pelvic floor exercises, utilizing bulking agents such as collagen and sacral nerve stimulation. Also, medications pertinent to stress incontinence would be anticholinergics or oxybutynin, duloxetine, or estrogen therapy. Estrogen therapy you would utilize for atropic vaginitis if that was the cause. Also, more specific to female patients experiencing stress incontinence, their stress incontinence may be due to prolapse of pelvic organs, therefore a vaginal mesh procedure, sling procedures, or a pessary is a viable option. Reasons for urology referral are unsuccessful behavioral interventions, unsuccessful pharmacological interventions, patients experiencing overflow incontinence with a post-volume residual of greater than 200 cc's, any unresolved urinary tract infection, unresolved hematuria, and unresolved proteinuria, and other indications from current or past medical history that suggests a urology referral is significant prostate enlargement, persistent pelvic pain, and new onset incontinence with neurological symptoms. Because urinary incontinence is not a diagnosis, it is a symptom, it is important to determine whether it is transient or chronic. Transient urinary incontinence could be due to delirium, infection, impaction, or inflammation, atrophic vaginitis, psychological, pharmaceutical, or psychotropic issues, endocrine problems, restricted mobility, or stool impaction. Diagnosis pertinent to RW would be number one, infection, because of his symptoms and his history of BPH, symptoms being hesitancy and dribbling with urination. Cognitive impairment could be leading to his urinary incontinence because we know that he has cognitive impairment as evidenced by the MMSE. And we also know that cognitive impairment could lead to urinary incontinence. As I stated, benign prostatic hypertrophy, which is part of his current medical history. Functional urinary incontinence, he does have peripheral neuropathy and gout. and um, some limitations in his ability to function as evidenced by the screening tools used. And with any functional limitations, the patient may be unable to get to the bathroom in time, which could lead to incontinence. And lastly, overflow urinary incontinence, also as evidenced by his symptoms of hesitancy and dribbling, as well as benign prostatic hypertrophy. The final diagnosis chosen for RW is overflow urinary incontinence due to his symptoms of hesitancy and dribbling with urination, as well as his history of benign prostatic hypertrophy. The other three diagnoses were ruled out based on his review of systems, physical exam, diagnostic labs and procedures, and screening tools. RW has no identifiable community resource needs at this time. The multidisciplinary team part of RW's care is his primary care provider and VA doctor that he sees annually. He does not require a urologist consult as indicated by his management with his BPH and urinary incontinence. And he also sees an ophthalmologist and dentist yearly. RW's health behavior demonstrates compliance and good health management. Not pertinent to RW, but some social determinants with your experiencing urinary incontinence are issues with social isolation due to embarrassment, which impacts the quality of life. The patient may develop a form of depression and hopelessness. Also, these patients are at risk for failed relationships. I can imagine these social determinants would impact one's will to live. Socioeconomic and cultural issues. Urinary incontinence due to functional limitations may require community assistance, hygiene and medical devices, and pharmaceutical expenses. Fortunately, RW is somewhat self sufficient in his home care, requiring assistance occasionally from his wife. Home health and PT was offered and declined from the patient and the patient's wife. She states that the little assistance RW requires is tolerable. RW and his wife both state that he utilizes the recumbent bike they have in their home and is active with walking as well, totaling greater than 60 minutes of activity a week. And there are no legal ethical issues identified in this case.